Module 6, Cardiac. This recording will cover Chapter 31, Coordinating Care for Patients with Vascular Disorders. So a quick little recap, we're going to talk about vascular disorders. So we're talking about our vessels, our arteries, veins, and capillaries. Their job is to transport blood and to transport waste. So our tissue in our body requires a minimum amount of blood per minute to sustain its metabolic activities and remove waste. So, for example, our kidneys requires a certain amount of volume and a certain amount of pressure in order to make urine and to keep its own organ working how it should work. So we need a minimum amount of blood. Okay, so usually the primary culprits in many vascular problems, many vessel problems, are going to be related to arteriosclerosis and atherosclerosis. So arteriosclerosis is the umbrella term. Arterial means arteries and sclerosis means thickening or scarring of an artery wall. So this is often associated with aging because it is an age-related change. It causes stiffness and loss of elasticity in those vessels. There are three possible processes that contribute to arteriosclerosis. The first one is medial calcific sclerosis. And this is when calcium is deposited into the arterial wall, making it stiff and not elastic. Arteriolar sclerosis, this is thickening of the smaller little arterioles. And then we have atherosclerosis, also known as plaque. This is when LDL particles build up in the arterial wall, and that is the most common and what we are focusing on pretty much throughout this whole vascular disorder lecture. And here we are, atherosclerosis. So this is a slow, complex disease that usually starts in childhood and is progressive. So this happens over time, and most of us, if we live to be 100, will have atherosclerosis to some degree. If you have patients who have these certain risk factors, then their atherosclerosis will be much worse. So the pathophys. So vessel damage triggers an inflammatory response. So this vessel damage can be from smoking, it can be from hypertension. There are many things that can cause vessel damage in the endothelium, which is the inner lining of our vessel. Inflammatory response means that our body is going to send white blood cells, it's going to send platelets, things are going to get sticky there, there's going to be clots forming around this damaged vessel. It's going to result in hard, thick vessels and those formations of those plaques. Risk factors: high cholesterol, high triglycerides, high LDL, low HDL, hypertension, diabetes, smoking, family history, obesity, and sedentary lifestyle. Remember, there are modifiable risk factors and non-modifiable risk factors. So out of this list, it looks like the only non-modifiable risk factor is family history. So there's a lot of education that can be done here. Signs and symptoms of atherosclerosis. So remember that all that atherosclerosis is plaque formation in the artery wall, and that will over time make that artery become narrower and narrower. It could possibly even become closed off and obstructed. So you don't really see any signs and symptoms at first until there is critical narrowing of the artery. So the patient might have increased fatigue or weakness or new or worsening exercise intolerance. That's usually like the beginning. If there's critical narrowing, that means there's going to be a medical emergency. This can lead to myocardial infarction, sudden cardiac death, stroke, and gangrene. And it really just depends on which artery is being affected by that obstruction. So treatment. We can't reverse atherosclerosis, but we can hopefully slow the progression. This is going to be by undoing those modifiable risk factors. So stopping smoking, decreasing LDL, taking your cholesterol meds to decrease your cholesterol, anticoagulants to kind of calm down our body from aggregating to that area and making the obstruction worse. Dietary changes, so low fat diet, high fiber, low sodium. Lifestyle changes, so include exercise every day if possible. Lose weight if you're obese, and just teaching on the disease process and all of these things that the patient can do to prevent it from getting worse. Surgical management. Usually there is no surgical management done for atherosclerosis unless there's something happening like a myocardial infarction, or like pictured here, it is the artery is so occluded that now tissue is dying, and then the patient needs either to open up that vessel or even amputate. So atherosclerosis can lead to hypertension, carotid artery disease, and peripheral vascular disease. So your assessments, you're going to get a good patient and family history, blood pressure, pulses. For this chapter, we are we are making sure we're doing our neurovascular assessments. So we're checking pulses, we're checking temperature, color. We're auscultating for bruise. Bruise is a swishing sound that we don't want to hear most times. So in this case, bruise are bad. We want to take a look at all their labs, especially lipids, triglycerides, homocysteine, and their A1C to see if they have diabetes or if their diabetes is controlled. So part of our interventions are also going to include making sure they take their meds, including antihypertensives and lipid-lowering drugs like statins for cholesterol. Okay, that's it for atherosclerosis. We're moving on to the silent killer, hypertension. So hypertension, anything that increases cardiac output, increases peripheral vascular resistance, and increases your heart rate could potentially cause your blood pressure to increase. Risk factors include race, gender, socioeconomic status. So gender-wise, females are more likely to get hypertension in the later years than males. There are two types, essential hypertension or secondary hypertension. For our purposes, we are just saying hypertension. So there are some mechanisms in our body that are made to keep us in homeostasis and to increase our blood pressure when it goes too low. So examples of that are increasing sodium intake. When you increase sodium intake, it encourages fluid retention, so that could potentially up our blood pressure. The RAS system, that is when the kidneys sense that there is low blood pressure, so it releases the hormone renin and it kicks in that RAS system to increase our blood pressure. The RAS system includes aldosterone. Aldosterone is a hormone that acts on the kidneys to keep sodium and in turn fluid. And then our sympathetic nervous system, our fight or flight response, will also kick in to hopefully raise our blood pressure if it goes too low. So how do we classify blood pressure? So let's take a look at this table. So we all know that normal blood pressure is 120/80, and the higher you go, you will enter different stages of hypertension. So if your blood pressure is 120 to 129 systolic, we're going to say that you have elevated blood pressure. You could also say that you're pre-hypertensive. With that one, we're just going to educate because it's low enough that the patient still has time to make some lifestyle changes and reverse it that way. As you go up to stage 1 and stage 2, medication will start to be considered depending on the patient. Hypertensive crisis, that patient needs IV medication to drop that blood pressure. And that's pretty much all we're going to talk about those stages. The clinical manifestations of hypertension are really not going to be seen until the disease is advanced. That's why it's called the silent killer. When you do start to have signs and symptoms, you can see headaches, chest pain, vision changes, shortness of breath, renal problems, dizziness, fatigue, nosebleeds, and this is all directly tied to the damage that high pressure blood is doing to the vessels. Diagnosis. We need to confirm that the blood pressure is accurate when we are documenting. Whether it's in the hospital or at the doctor's office, it is your responsibility, if that is your patient as an RN, to make sure that it was obtained accurately. So once you get a good reading and it is elevated, we're going to take it again just to make sure that it's real, because there are a lot of things that can influence our blood pressure. Once you confirm 2 or more high blood pressure readings on 2 different office visits, then the patient may get started on treatment. If they have 2 blood pressure readings in one office visit and the blood pressure is like really high, like 190 over something or 180, and it's confirmed to be true, then they may immediately treat the patient with medication. So it really just depends on how severe it is at that time. Hypertension complications. So we are looking at target organ damage, so TOD for short, and 3 of those target organs include the heart, kidneys, and our brain. So we're just going to talk a little bit about how hypertension affects these organs. So in our heart, that high pressure causes the heart to really work overtime. So we have increased afterload with hypertension. This is going to cause those ventricles to kind of work overload. They can become really thick, it can become dilated, and then you have other problems. Kidneys. So we have lots of little tiny vessels in our kidneys, and they begin to thicken over time, which narrows the lumen, and this is all from that high pressure blood coming through. So eventually the blood supply to the actual kidneys is going to be reduced because of the thickening. And so if there's reduced blood supply to the kidneys get scared and start producing renin, which is going to kick the RAS system into gear, which is going to raise the blood pressure more, which worsens the problem. Eventually, all of that reduced blood flow is going to end up in renal failure. It's going to just kill the kidney. Then we have our brain. So if you have high pressure for a long time, you can actually cause the vessels in the brain to rupture, which is going to be a hemorrhagic stroke. So not good. So patients can also have a hypertensive crisis. So hypertensive crisis is a really high blood pressure, and it is categorized into urgency and emergency. So hypertensive urgency or hypertensive emergency. So the urgency one means the patient's blood pressure is really, really high, but there isn't any obvious target organ damage. Versus hypertensive emergency, the blood pressure is really high, but they are showing signs of target organ damage with an example would be like a stroke. So that would obviously be an emergency. So why does this happen? Older adults, African Americans, and males are at risk, and usually it's going to be related to patient taking medications that are interacting with another medication, or maybe the patient just stopped taking their blood pressure medication. So that is usually the reason. So you want to make sure you're educating your patient on how important it is to take their meds consistently. Peripheral artery disease, or PAD. So the pathophys on this is obstruction of blood flow through large peripheral arteries cause partial or total occlusion. So this just means that we're talking about arteries. They are becoming narrowed, and narrowed so much that it starts to block blood flow. And the risk factor is atherosclerosis. So we know all about atherosclerosis. Those modifiable risk factors: smoking, hypertension, diabetes, dyslipidemia, sedentary lifestyle, and ineffective stress management. So there you go. That's everything that you're going to need to identify your patient, and then you're going to educate your patient. Clinical manifestations of PAD depend on the stage of the disease. So if it's early, then the patient will be asymptomatic. And how do we know that they have this and they're asymptomatic? It's going to be based on a physical assessment. So the patient's not complaining about pain or anything like that, but the provider or you, the nurse, may feel that pedal pulses are decreased or absent. You might hear bruise in vessels. So that could be an indicator that the blood flow is not going through and they have PAD. So stage 2 would be claudication. So claudication or intermittent claudication is when the patient has aching, cramping. It could be numbness. It can feel like muscle pain, usually in the calf. And this is relieved when they rest. So that would be intermittent claudication, and that is stage 2 of PAD. Then stage 3 is called rest pain. So this means they have pain at rest. So maybe before, when they sat down for a bit, the pain subsided, but now the pain is always there. The pain can awake them while they're sleeping, and the pain can actually sometimes be relieved if they dangle their legs, and that means that the blood is like going down. That's the only way that the blood can actually make it to where it needs to go. Stage 4 would be necrosis or gangrene, and this is when the obstruction is really bad and that oxygen-rich blood is just not getting to where it needs to go. Usually it's going to affect the most distal areas, the most distal or the most farthest away from the heart. So like the toes, the heel of the foot, they can develop ulcers, gangrene, wounds. Okay, so the takeaway from here: patient will experience intermittent claudication. It can be severe, it can be debilitating, or it can be mild. A telltale sign will be diminished pulses in the feet and pale extremities when they are elevated. Diagnosing PAD is going to include a good history and physical, a good vascular assessment, including pulse, palpating, auscultating for femoral bruits, inspection of the legs and feet, so a good neurovascular assessment. We want to rule out other calls that can potentially have the same signs and symptoms. We can also do an ankle brachial index, or ABI. That's where we take the blood pressure on the arm and the ankle. You divide it, you get a number, and if you look at this little box here, if your ABI is low, or the lower it is, the more severe your PAD is. We can do ultrasounds to assess blood flow. They can do angiograms if there's an obstruction, or to detect small obstructions that they can't see, like on an ultrasound, and blood tests to see, risk factors. Treatment is going to be to prevent progression. We can't undo atherosclerosis, so we're just going to try to prevent and manage the symptoms. Medications are going to be geared towards those modifiable risk factors, so statins for cholesterol, antihypertensives for blood pressure. And then we're also going to put some antiplatelets in there, because our body will naturally send platelets that are sticky to stick to things that are not supposed to be there, like a narrowing vessel. Surgical management. Usually that's not done unless there is really bad obstruction. So pictured here, they can put in stents, they can kind of go in and do a laser. So this is really just depends on the situation. Complications. They can lose limbs, they can have chronic ulcers, and this is all due to the circulation or lack of circulation. Assessments. We want to take bilateral blood pressures, because in peripheral artery disease, which could include the upper and lower extremities, they will typically have different blood pressures on different extremities. You want to make sure you're palpating all pulses. Remember, we're talking about arteries, and when you are taking a pulse, you are feeling the artery. So it's really important that you are checking those pulses. You want to look at the feet, you want to look at the limbs. We're checking again. This is our neurovascular assessment. And also assessing for pain. Teaching. So with PAD, we are dangling to facilitate blood flow. That way gravity can help pull the blood that's flowing through the artery down to the most distal part of our body, our feet. Patients should report chest discomfort or chest pain. Chest discomfort or chest pain. That can be a myocardial infarction. And then, of course, lifestyle changes. Next is carotid artery disease. So this is just another artery. It's just in our neck. It's a carotid artery. This is going to end up with vessel wall thickening and plaque formation. Again, risk factors the same: smoking, hypertension, diabetes, dyslipidemia, sedentary lifestyle, obesity, and ineffective stress management. Because our carotid artery feeds our brain with oxygen-rich blood, if it becomes obstructed, we are going to have a stroke. So we want to know those signs and symptoms of a stroke, and we also want to educate our patient on those signs and symptoms if they have been diagnosed with carotid artery disease. So just as a recap, the signs of a stroke could be sudden weakness, dizziness, loss of coordination, slurred speech, facial droop, vision problems, or sudden and severe headache. So diagnosis, you can auscultate a carotid bruit, okay, because blood flow is not nice and smooth. There's going to be turbulent blood because it has to go through these narrowed arteries. They can do a Doppler to check blood flow, which is an ultrasound, a CT angiogram, an MRI, and carotid angiogram. It just depends on the patient. Medications, healthy lifestyle changes, and management of comorbidities. That's going to be the goal. Surgical management, they can do a carotid endarterectomy, carotid artery stenting. These are very risky surgeries, but there is an option to do those if the patient meets that criteria. Interventions, we're going to make sure they're taking their blood pressure meds, their cholesterol meds, and antiplatelets. We want to make sure they have their diabetes under control. We're going to teach them signs and symptoms of stroke and educate them about the DASH diet, which lowers blood pressure and that bad LDL cholesterol. Next, we have aortic artery disease, also known as an aneurysm. So an aneurysm is a permanent localized dilation of an artery that forms when that middle layer of the artery is weakened, and it produces a stretching effect in the inner layer. So as the artery widens, tension on the wall increases, which makes it worse, and then the aneurysm enlarges. Okay, so risk factors. This can run in families. Advanced age, so 60 years old and older. Male gender, smoking, atherosclerosis, hypertension, high cholesterol, known cardio or carotid artery disease, and some genetic abnormalities. Clinical manifestations of aortic artery disease. won't be seen until it's gotten bad. So it's going to be asymptomatic until dissection or rupture occurs. So you may be able to see a palpable pulsatile mass in the abdomen with a AAA. That's an abdominal aortic aneurysm. So that is kind of like right below your xiphoid process. If you're lying flat on your back, sometimes you can see with this disease, little pulsatile mass. And if you ever see that on a patient, you don't want to palpate it. You don't want to be pushing around on that. You want to be very gentle. So this may also cause chest, back, or flank pain, depending on where that aneurysm is located. And if a patient has pain, so say they have history of a aneurysm, a known history, and then they start to have pain, that usually will mean that there's something changing with that aneurysm and they should go follow up with their provider. Diagnosing an aneurysm, the gold standard is going to be a CT scan with IV contrast. They can also do, and this really depends on where it's located, a transthoracic echocardiogram, cardiac MRI, and also do a 12-lead EKG just to rule out MI. Medications to control your blood pressure and medications to control your high cholesterol. So 75% of aneurysms are due to atherosclerosis, just FYI. Surgical management really depends on the patient, risk versus benefit, and how large the aneurysm is. But there are some surgical procedures that they do for that. Complications include aortic dissection and aneurysm rupture. So they believe that a dissection happens when there's a little tear in the layer of the artery wall, and then blood kind of rushes in and creates like a little pocket within that artery wall, which is pictured here. An aneurysm rupture is just that. There's actually blood rupturing from the aortic aneurysm. And this is definitely life-threatening because the aorta is a high-pressure vessel, and the death rate in all patients with a ruptured abdominal aortic aneurysm is around 80%. So not many survive that. And just to note that when it ruptures, sometimes it's just a little tiny ooze. It can just be kind of like a drip, but it can turn into a huge rupture at any time. But most of the time, the patients don't even make it to the hospital because they die that quickly. All right, so usually asymptomatic until rupture or dissection. Only 5 to 10 of the patients experience those symptoms like chest, back, or flank pain, and it really just depends on the location of the aneurysm. So what I want you to remember here is if a patient has an aneurysm and then they start to experience severe low back pain, that usually means that it's rupturing. So that is a medical emergency. Your assessments are going to be just like all the others: vital signs, neurochecks, pain, and then your general neurovascular assessment. And of course, you want to be gentle on the abdominal palpation if you do that at all, and of course be gentle when you're auscultating. So interventions, you're going to give the blood pressure meds, cholesterol meds, stool softener, create a calm environment, and you're going to teach the patient of signs and symptoms of an aneurysm and a dissection if they've been diagnosed with an aneurysm. And they should follow a strict regimen, follow their meds, stop smoking, maintain healthy weight, regular exercise, all of those things that we typically educate our patients. Okay, we're moving on. So here we have a picture of a really, really big blood clot, bringing us into deep vein thrombosis, or DVT. So venous thromboembolism, or VTE, is the umbrella term that encompasses DVT and PE. So pathophys, Virchow's triad. This is going to be the recipe for disaster. So if you have decreased flow rate of blood, damage to a blood vessel wall, or increased tendency to clot, that looks like you're going to get a DVT. So this may lead to pulmonary embolism, and we're always thinking that if you have a patient with DVT, we're always looking out for respiratory abnormalities. Risk factors for a big clot in your vein: increased age, active cancer, varicose veins because that causes pooling, prior venous DVT, you already had a clot, pregnancy or postpartum, oral contraceptives, or any kind of hormone therapy, like if you are going through menopause, immobility such as after surgery, after trauma, if you are in long-term care, if you are immobile, big risk factors there. Signs and symptoms are going to be signs of our inflammatory response. So pain, swelling, tenderness, discoloration, redness, and warmth. We expect our patient to have that if they have a DVT. Diagnosis, we're going to ask questions, get a good history and physical. We can run a D-dimer. The D-dimer measures fibrinolysis, meaning the fibrin that's wrapped around in blood clots as it's getting broken down by our body, we can measure that. And if you have a high D-dimer, that might mean you have a clot somewhere. Compression ultrasound can measure blood flow of those vessels. Prevention, so we want to always prevent our patients from even getting a DVT in the first place. Early ambulation or ambulation period is always great. VTE prophylaxis, that can mean compression stockings, sequential compression devices like SCDs, or it can mean like Lovenox or heparin sub-Q. Medications, like I said, heparin or Lovenox sub-Q, warfarin. Those patients, as a reminder, have to get routine blood work to make sure that their INR stays within range between 2 and 3. And then we also have direct factor 10A inhibitors like apixaban, aka Eliquis. Surgical management to treat DVT. So that's not really used that often. It's usually not necessary, but if you remember that picture that I showed you of that big clot, that required surgical intervention because it was so big. So there are some options depending on the patient. Assessments, vital signs, neurovascular assessment, gentle palpation. Whenever you have potential or confirmed presence of a clot, no massaging, no palpating the area because you could dislodge it. Complications include pulmonary embolism. I cannot tell you enough. If you have a patient with DVT, you always consider those respiratory signs and symptoms. Shortness of breath, pulse ox is going down, and they have a DVT, we're suspecting PE. Post-thrombotic syndrome. So that happens once everything has been resolved. The patient no longer has a clot, they've been treated, they're good to go, but they still have these bouts like they have a clot, like those inflammatory, some discomfort, pain, swelling. But it's just a syndrome that happens. They don't know why it happens, but it is sometimes it happens. So interventions after the patient has already had a DVT. So walking is still there, leg elevation to increase circulation, compression stockings. We don't want to use the leg squeezers. We don't want to use the SCDs because that has a massaging action and we don't want to massage any blood clots. We want to encourage adequate fluid intake because that makes our vessels, everything inside our vessels, nice and dilute. Nothing will get stuck. And then we want to give whatever medications are ordered. So teaching, prevention of reoccurrence. If the patient is sedentary, then we want to make sure that they're walking. If they are dehydrated, we want to make sure that they maintain their fluid intake when they go home. We want to make sure they know signs and symptoms, like they report bleeding because they're going to be on anticoagulants. If they're taking warfarin, they need to go get their blood checked regularly. And then bleeding precautions. This slide is a general overview for venous insufficiency interventions. So this is when you just have bad venous return. So you want to elevate the legs for at least 20 minutes, 4 to 5 times daily. This is different from peripheral artery disease because we want to dangle our legs to help gravity pull blood down. When we're talking about venous insufficiency, we want to raise the legs above the heart, especially while in bed. We want to avoid crossing legs. We want to wear elastic compression stockings. They should be applied when swelling is at a minimum, so they're easier to put on. And then if the patient has any kind of wounds or ulcers, which they might have with venous insufficiency, then we don't want them to wear compression stockings. Okay, and that concludes this chapter.